Call is now being recorded.
Are in a listen-only mode until the question and answer session of today's call. At that time, if you would like to ask a question, please press star 1. Today's conference is being recorded. If you have any objections, please disconnect at this time. I would now like to turn the meeting over to Ms. Stephanie Joseph. You may begin.
Good afternoon, everyone, and thanks for your participation in today's stakeholder call. My name is Stephanie Joseph, and FDA's Office of Health and Constituent Affairs. Today's call is a briefing for our valued stakeholders to discuss the release of a draft report for a risk-based regulatory framework for health information technology, or Health IT. The report includes a proposed strategy and recommendations for a framework that promotes product innovation while protecting patient safety and avoiding regulatory duplication. The report was developed by FDA in coordination with the HHS Office of the National Coordinator for Health Information Technology, also known as ONC, and the Federal Communications Commission, or FCC. FDA's news release on this announcement has posted to our website and has been distributed to all of you. I'm joined today by Dr. Jeffrey Shuren, Director of FDA's Center for Devices and Radiological Health, and I'm also joined by Jodi, Director of ONC's Office of Policy Planning. And also with us today is Matthew Quinn, Director of Healthcare Initiatives at FCC. Dr. Shuren will provide an overview of the collaborative effort and the report. Jodi will discuss ONC's role under the proposed framework, and Matt Quinn will provide perspectives about FCC's role. Following these remarks, we'll hold the question and answer portion of the call. During that time, representatives from FDA, ONC, and FCC will be available to answer questions. All parties will be in listen-only mode until we open the call for questions. With that, I'll turn it over to Dr. Shuren.
Well, thank you, Stephanie. Good afternoon, everyone, and thank you for joining the call. I'm Jeff Shuren, Director of FDA's Center for Devices and Radiological Health. As you know, we're here today to talk with you about the proposed strategy and recommendations for a framework for health information technology that was posted today on each of our agency websites. We think this strategy promotes innovation, protects patient safety, and avoids regulatory duplication. Health IT offers a huge range of potential benefits to patients and healthcare providers. These products and technologies can help prevent medical errors, improve healthcare quality and efficiency, reduce costs, and increase consumer engagement. They can help expand the boundaries of clinical research and help quickly identify, quickly respond to public health threats. Many of these exciting innovations are already transforming the way healthcare is delivered. But as with all medical technologies, some health IT products can pose risks if they are not designed, developed, implemented, maintained, and used properly. As part of the federal law passed in 2012, the U.S. Congress directed the FDA, working with ONC and FCC, to develop a proposed strategy and recommendation. We immediately pulled together a 28-member multi-stakeholder work group under ONC's Health IT Policy Committee, with experts representing patients, consumers, healthcare providers, health plans, venture capitalists, and the medical device and IT industries. This group met nearly 30 times, all open public meetings, and developed recommendations they presented to ONC's Health IT Policy Committee to inform our strategy and framework. Creating such a framework is a big task. As Congress requested, the framework covers the full range of health IT products, from the very simple electronic appointment scheduler to the much more complex electronic development of radiation treatment plans for individual patients. The open and transparent way we engage with the public has led to a draft framework that the three agencies believe will come to serve as an example of how public policy on such broad issues can and should be developed. As a result of this process, we are proposing for public comment a limited, narrowly tailored approach that relies primarily on ONC-coordinated activities and private sector capabilities and practices to assure safe, high-quality health IT. We believe that no new regulation should be or needs to be the first approach used to reach these outcomes. Government oversight can and should protect the public as well as promote innovation. That is smart regulation. This draft framework outlines just such a strategy. It is a risk-based approach focused on function and the level of risk posed if that technology fails to perform as intended. So we're first asking, what is the product intended to do, rather than what is the product or what is the product platform? We're also asking, what's the risk to patients? Based on function and risk, the proposed framework divides health IT into 3 categories. The first category is administrative health IT, products that pose little or no risk to patient safety and do not need additional involvement from ONC or FCC or oversight by FDA. These products include billing, claims, and scheduling software. The second category is health management health IT, such as medical management software and most clinical decision support software. Efforts to assure the safety of products in this category will be led by ONC and includes products that are sufficiently low risk such that even if some of the products may meet the statutory definition of a medical device, FDA does not intend to focus on them. The third category is medical device health IT, such as EKG software and computer-aided detection software used to identify possible tumors on radiological images. These are the kinds of medical device functions FDA has traditionally regulated, in some cases for several decades, and would continue to regulate. Therefore, we're recommending that no new areas of FDA oversight are needed. Instead, the proposed strategy is focused primarily on health management health IT, for which ONC would have primary responsibility. We recognize that any categorization scheme will be imperfect and may need to adapt over time. Maintaining flexibility is important for assuring that any framework can effectively protect patient safety and promote innovation for both today's technologies and future yet-to-be-imagined health IT products. Moreover, given the broad range of health IT functionality, a one-size-fits-all approach won't work. Our proposed framework is intended to address current functions and technologies while being sufficiently agile to accommodate future and innovative, continuously evolving products, as well as the future evolution of the systems and environments in which specific health IT products are used. Our proposed strategy contains 4 key priority areas. Each priority area can be tailored to the specific function using a risk-based approach, has relevance at all stages of the health IT product lifecycle and to all health IT stakeholders, and supports both patient safety and innovation. First, to promote the use of quality management principles by health IT stakeholders, as advocated by the Institute of Medicine in their report on health IT and by the multi-stakeholder work group we established to inform this report. Quality management principles can help assure the safe design, development, implementation, customization, and use of health IT through identification, prevention, tracking, and monitoring of safety hazards and reducing risks. Health IT, particularly health management health IT, is typically used not in isolation, often is integrated into a system customized by the purchaser to meet the needs of its users. Therefore, it is important that quality management principles be adopted and employed by all stakeholders involved in the life cycle of a product to assure its safe use. Second, to identify, develop, and adopt applicable health IT standards and best practices to help deliver consistently high-quality health IT products and services to consumers. Standards and best practices, such as for interoperability among health IT products, can set the minimum expectations necessary to achieve an acceptable level of performance and can serve as a guide for achieving performance excellence. Third, to leverage conformity assessment tools such as product testing and certification by independent entities to assure that health IT products, services, systems, and organizations meet specified standards or fulfill specified user requirements. These tools can be applied in a risk-based manner to distinguish high-quality products, developers, vendors, and organizations from those that fail to meet a specified level of quality, safety, and/or performance. And fourth, to create an environment of learning and continual improvement. Such an environment would provide transparency about products on the market, identify, report, and respond to health IT-related adverse events and near misses, aggregate and analyze such reports to identify patterns and trends, share important information, support the development and adoption of effective interventions and mitigations, and promote system-wide education and learning. Importantly, today's report is a proposed strategy and recommendations, not a final framework. We believe it is essential to have a public dialogue about the proposals contained in the report. To that end, we'll hold a multi-day public meeting later this spring. In the interim, we're opening a public docket to accept comments immediately. And now I'll turn it over to Jodi Daniel to discuss other critical aspects of the proposed framework. Thank you.
Thank you, Dr. Shuren. I'm pleased to be here with my colleagues from FDA and FCC to release the proposed FDASIA report. The Office of National Coordinator for Health Information Technology, or ONC, is the office within HHS that is charged with coordination of nationwide efforts to implement and use health information technology to improve health outcomes. In that role, and in considering our role in regulating health IT through our certification program, we were tasked to work with the FDA and FCC on the development of the draft FDASIA report. As Dr. Shuren said, the draft report is based on extensive feedback and input from all across the health IT and healthcare industries, as well as from consumers. It presents three categories of health IT based on function and level of risk, based on what the product does, not the platform, such as mobile device, PC, or cloud, on which it operates. Here at ONC, with input and support from industry, we will be focusing our attention on the second category that Dr. Shuren mentioned, health management, health IT functionalities. These include the functionalities that ONC certifies as EHR technology. These functions are implemented in complex environments where responsibility is distributed by various actors, such as developers, implementers, and users. And safety requires action across all of these entities. In addition, working closely with our colleagues on this call, those at the Agency for Healthcare Research and Quality, other agencies and stakeholders from across the world of healthcare, we recommend the creation of a Health IT Safety Center, which would be a public-private entity with broad stakeholder engagement. The Safety Center was proposed in the President's 2015 budget, and we expect that it will help improve the body of evidence available on health IT safety, identify best practices for improving patient safety, and provide a forum for the exchange of ideas and information focused on health IT safety. So as you can see, the release of the draft report is only one step in the development of a risk-based regulatory approach to health IT. This approach will require commitment, action, and accountability from everyone involved in health IT. We encourage all stakeholders to comment on the proposals we released today, so please comment directly to the proposals or join the public meeting we will hold in May. More information will be coming shortly. Thank you for joining us today, and with that, I will turn it over to Matt Quinn.
Thank you very much, Jodi. I'm happy to be here today with you and with my colleagues from ONC and FDA. You might be wondering, what is FCC's role in the framework? The framework reflects the FCC's narrow but important roles in both encouraging new and innovative wireless medical technologies and ensuring that developers and users of these technologies are minimizing the potential for causing harmful interference to radio services. The FCC manages use of the radio spectrum by the private sector and sets technical standards for transmitters and other equipment to minimize their potential for causing interference to radio services. The FCC also runs an authorization program to ensure that equipment reaching the market complies with these technical requirements. Health IT and any other device that transmits radio frequencies, smartphones, wireless microphones, baby monitors, etc., continue to require FCC authorization. So what is FCC doing to facilitate innovation, protect patient safety, and avoid regulatory duplication? The FCC seeks to make more licensed and unlicensed spectrum available for mobile health innovation. One example is the Commission's May 2012 order to allocate spectrum for medical body area networks, making the U.S. the first country in the world to make spectrum available for this specific use. In addition, the FCC's January 2013 experimental licensing order to expand existing experimental radio service rules to promote cutting-edge research and foster development of new wireless technologies. Through what are called medical testing licenses, qualified healthcare facilities would have broad authority to conduct research without the need to seek new approval for each individual experiment. This will help facilities and industry more broadly better evaluate how wireless technologies and other electronic devices coexist in a hospital environment. Since FCC and FDA signed a memo of understanding in 2010, the agencies have been working closely on issues related to FDA-regulated medical devices that use radio frequencies. And the goals of this MOU were to further enhance information sharing, improve the efficiency of the agency's regulatory processes, and to promote efficient utilization of tools and expertise for product analysis, validation, and risk identification. The FCC is participating in a similar MOU or Memo of Understanding that includes both ONC and FDA to focus on the full array of health IT. Key future collaborative activities include hosting a workshop on wireless test beds, tentatively scheduled for September of this year, and development of guidance, of course with feedback from stakeholders on potential opportunities for regulatory efficiencies for wireless systems that must undergo both FDA and FCC review. With that, I'll turn it back to Stephanie. Thank you.
Thank you, Matt. At this time, we will begin the question and answer portion of the briefing. When asking a question, please state your name and affiliation. Also, please limit yourself to one question and one follow-up so that we can get to as many questions as possible. Operator, we'll begin by taking the first question.
Yes, thank you. And if you would like to ask a question, again, yes, you can press *1 and record your first and last name clearly when prompted. Your name is required to introduce your question. To withdraw your question, you may press *2. Once again, if you would like to ask a question, please press *1. One moment, please, for our first question.
While we wait for our first question, I'd like to remind you all that a replay of this afternoon's call will be available in about an hour and will be available for 30 days by calling 800-879-6177 with a replay passcode of 5440. For international callers, that number is 203-369-3567 with the passcode again being 5440.
Our first question is from Julian Goldman from the MA General Hospital Partners and Partners Healthcare. Your line is open.
Hi, thank you for taking my question. I'm curious about if there will be any change to the submission of devices, health IT-related products or the like, from the agency perspective. Will FDA still be the point of contact for submission, or will ONC be the contact, and how would a manufacturer decide?
The answer is no. It's really the same as before. This report is not, touching on the medical device space. It's kind of laying out the framework here for health management, health IT.
So, if I understand correctly, if there is a quote submission is required, that implies that it is something that would be following the FDA pathway as it does today. Do I understand correctly?
Yes. Now, one of the things if you're in the medical device bucket and your software is a medical device, something that we've been regulating for several decades, we and actually several of the countries are revisiting the overall approach for how we think about risk and controls for software as a medical device. Actually, we just posted from the International Medical Device Regulators Forum a proposed framework for software as a medical device. And this was signed on by, it's not just the U.S. FDA, it's the European Union, it's Canada, Japan, Australia, Brazil, China, and Russia, to try to assure that in the medical device space, so again, this is not talking about what is a medical device. For those things that we are regulating, because we're not proposing any new regulation, for those things that we are regulating, software as a medical device, we with the international community are actually revisiting that framework to better account for approaches that best meets the needs for this very rapid innovation cycles that we see in software. Thank you.
Thank you, Dr. Goldman. We'll take the next question.
Our next question is from Morgan Reed from ACT. Your line is open.
Thank you very much for taking the call. And first of all, I want to thank Dr. Shuren, Jodi, and others who worked on making this possible, and a special call out to Bakul Patel and Joy Pritz for their input as well. But it raises an important question. The idea of a safety IT center is obviously a good one, but one of the things that Bakul and Joy Pritz and others we've all been discussing is how to get the message out from the silo of health IT and out to developers. What are your plans to take the information that resides in this new center and bring it to those who are in the developer space rather than requesting that they come to you for the information? Is that something you guys have thought about? And if so, how can we work together to pursue that direction?
Yeah, so this is Jodi Daniel. We are proposing the creation of this safety center. I think a lot of the details still need to be worked out, and we are seeking public input on how best to do that. So we look forward to hearing from you and others about some of the either challenges or opportunities that we have to make the safety center something that is both accessible and useful for all the different stakeholders engaged in this space. We are looking at the safety center being used as a mechanism for disseminating information and learning, both with respect to evidence as well as with respect to best practices. And we would hope that would be available to all different types of stakeholders, developers included. That said, we hope that developers would be part of the community that would participate in the safety center, both not just as a recipient of information, but also as a contributor to helping us understand some of the challenges, best practices, and the like.
Jodi, we look forward to joining you on that mission, and I think it's very much aligned with where the developer community is. We're both seeking information, but also ability to have input. And again, thank you and Dr. Shuren and the rest of the team for driving this forward through a very lengthy process where you took a lot of public input.
Thank you for your comments.
Our next question is from Dr. David Hirschhorn from University Hospital. Your line is open.
Thank you. Hi, this is Dr. David Hirschhorn. I'm calling from Staten Island University Hospital and also represent the American College of Radiology. I work with FDA a lot. So on that, a question with regard to, I noticed that you put clinical decision support squarely in ONC, and you put computer-assisted detection under FDA. One question that's always unclear to me is this, even in the previous draft guidances, is what about radiologic image viewing or medical image viewing? In the past, you've made this distinction between, well, is it for primary diagnosis or not? And the answer is yes. It could be either one. And is that going to change, and who regulates that? If you have a vendor who says this method of viewing radiologic images or medical images is not for primary diagnosis, it goes to ONC, and if it is, it goes to FDA, or how does that play itself out?
So, no, it's a very good point of distinction. So if it is the kind of technology that meets our classification rule that we have been regulating now for quite some time, we will continue to regulate it and regulate it as we have beforehand.
Okay. My concern is that the EMR is clearly something that's certified by ONC, and image viewing capability is being built into EMRs. And they say, well, that's not for primary diagnosis, is it? Or is it? That's the question. That's what becomes murky. Is a referring doctor looking at an image and making a decision and acting on the basis of that, and de facto that becomes primary diagnosis?
Yeah. So in this case, as we've said in the report, the founding principle is that we treat function the same. regardless of where it is. So if we're dealing with medical device functions that we have been, regulating, we would treat those the same, regardless of where they are located.
So even if they're in the EMR?
That's correct.
Okay.
Let me clarify one thing, that if there is something under this framework, if there is something that would be classified as a medical device health IT and in that third bucket, it would not necessarily make the entire product subject to FDA oversight, just because we're only focusing on the functionality. So that functionality, there may be functionality that is paired in with an EHR that FDA has traditionally regulated and continues to regulate, but it doesn't, it wouldn't necessarily bring in other functionality that is part of that product.
Thank you. That clarifies it. Thank you. I appreciate that.
Our next question is from Daryl Roberts from the American Nurses Association. Your line is open.
Hi, yes, this is Dr. Daryl Roberts. I'm the Health IT and Quality leader at American Nurses Association. My focus has been going back to the Safety Center. There is a lot of discussion ongoing in some work groups that I attend about creating a learning healthcare system that is going to be non-punitive in nature, and its non-punitive nature would help the developers and other members of the health IT community to bring risks, near misses, and non-catastrophic failures to the attention of others in the community without having to be concerned about being brought to some kind of a negative outcome. The way that this appears in the Safety Center is that it would be staffed by representatives from federal agencies who have oversight as part of their roles. How do you see separating the oversight role from the learning role in such a center, such that it would invite these near misses and non-catastrophic failures to come to the table to help in the learning process?
So thank you for the question. This is Jodi Daniel. So we are proposing to create a safety center, and I think some of the details like you're discussing need to be worked out, although it is something we've been researching and thinking about. There has been done in other industries where federal agencies have been players, but where there have been rules that have set up to promote confidentiality or anonymity with respect to information that is reviewed or considered within that environment. So, for instance, there in the aviation space, there are federal agencies that participate along with industry folks, industry stakeholders, to try to promote safety in the aviation industry with clear rules and protections in place to make sure that the agency, that it is a non-punitive environment. So I think the governance structure, and we did ask a question about that, still needs to be worked out, but I think that's a key consideration that would need to be addressed to make sure that folks are comfortable with participating in a learning environment. I'd also highlight that what we're proposing here builds on the patient safety organization structure that is a key focus of HHS, and particularly the Agency for Healthcare Research and Quality, where there are confidentiality provisions built in, and where providers can provide information about safety events without risk to them for doing so. So we would be looking at how we can leverage that existing structure in setting up the Health IT Safety Center in order to protect the confidentiality of participants and protect their participation in that activity.
So as a follow-up to that, the main question I would have would be regarding innovation. And with membership in PSOs, that generally is engaged by larger organizations. And as such, those larger organizations would be the organizations that had basically a lot more money at hand. With the smaller, very innovative organizations, it would seem that membership in a PSO might be a pretty heavy lift for them because they see that as something for larger groups. how would small business types of organizations, which tend to be the innovation drivers for health IT, be included if the PSO is the mechanism through which this might be done?
I think that we would look for input and comment on how best we can do that. I think our goal is to promote a environment and a trusted space for all participants in both the healthcare and health IT stakeholder communities. And if you have suggestions on how we can make sure to bring in those folks that may not have been been participating in the PSO structure currently, please let us know.
Thank you, Jodi.
Our next question is from Adam Tyner from the American Heart Association. Your line is open.
Yeah, that's Adam Tyner. I am a policy researcher with the American Heart Association here in the Federal Advocacy Office in Washington, D.C. This is somewhat of a segue to a previous question regarding agency-specific jurisdiction over the different categories, but it also involves applications or devices that have multiple uses or functions. Like, say, for example, you have an EKG monitor that obviously is a medical device, but, say, has a software component that has EHR functionality. What is going to be the regulatory approach to devices that have multiple functions that span categories?
So this is Jeff Shuren. Just going back to what Jodi had said previously, for FDA, we are just focusing on the medical device functionality, and that in those circumstances, that does not change how the EHR otherwise would be treated by ONC. So just because we're looking at certain functionalities, we're not looking beyond that.
Okay.
If you would like to ask a question, you may press star 1 and record your first and last name clearly when prompted. To withdraw your question, you may press star 2. Once again, if you would like to ask a question, please press star 1. Our next question is from Anna McAllister from Galileo Analytics. Your line is open.
Hi there. And that is my dog. This is Anna McAllister-Slip, and I am excited to read the report. I was part of the work group this summer, and one question that I have that isn't quite clear to me yet is for those of us who are patients who use medical devices that have a health IT application to read that device data, it's the way the situation has typically worked is that the device software tends to get cemented with the regulatory cycles of the physical device, which means that there can be no iterative further development or refinements to the software, or that's the way that it tends to happen until the next generation of that physical device is released, which can be 2 to 3 years. In the meantime, there could have been substantial improvements to the software. And I'm still not sure, based on my quick overview read of the report, how that would be addressed any differently than it currently is, and I'd just be interested in getting your perspective.
Well, certainly. So, again, this is Jeff Shuren. So this kind of falls under modifications made to devices, and here modifications made to software as a medical device. And one of the things we've said publicly is we would put out guidance to clarify an approach for how we handle modifications to software. First off, most changes that are made to software we don't ever review. And the focus is on what kinds of modifications really rise to the level that they have some touch by the FDA, and we are currently working with other stakeholders on what that framework would look like, with the goal in mind of being able to accommodate rapid innovation cycles, thereby promoting innovation and at the same time providing the appropriate level of patient protection. And you can anticipate in the future that that approach will rely much more heavily on a quality systems approach than we had in the past, and far less on a pre-market review for a number of kinds of changes.
Thank you.
Our next question is from Angela Jinson from the American Osteopathic Association. Your line is open.
Hi, good afternoon. Thank you. This is Angela Johnson. I just had a quick question regarding how comments will be held. I understand that you plan to have a comment period and also a workshop. Will a notice be published in the Federal Register seeking comments? And is there a particular date that's been determined in terms of the conference to solicit comments as well at this point?
So the answer is thank you for that question. We should clarify. Yes, there will be a Federal Register notice that will be published this Monday that will open up the public docket for comments. There will be a 90-day comment period. And then the public meeting is going to be held in May. And let's see.
And one follow-up, is there a specific date in May determined at this point, or is that yet to be determined?
Yeah, so it's May 13th through 15th.
Okay. And will that be Federal Register?
Yes, and there'll be information there in terms of registering for the public meeting.
Great. Thank you very much.
You're welcome.
Our next question is from Robert Shuren from Qualcomm Incorporated. Your line is open.
Hey, Dr. Shuren, Jodi, Matt, thank you for the briefing today. My question is about the report itself, referring to having initiated some activities to create the Health IT Safety Center with the expectation to launch in 2014. Can you give us a better sense of timing, given the open comment period, the May event, et cetera? How quickly thereafter can we expect the Safety Center to start implementing the framework?
So this is Jodi. We will be seeking public input through the public comment period as well as through the meeting that will be held in May to get more input on the Health IT Safety Center. As I had mentioned, we had put in the President's 2015 budget. There is the reference of the creation of a Health IT Safety Center. So that funding is, that budget is for 2015. We have been taking steps in the interim to start thinking about what a safety center would look like. And we have a contractor who has been looking at feasibility, different approaches, and helping us think through how we might structure such a center. So we have been taking steps to start thinking about it, thinking about what the scope would be, how we would set it up, and the like. But we would be looking for public input to weigh in on that before we actually set something up.
Once again, if you would like to ask a question, please press star 1.
Ladies and gentlemen, seeing no more questions in the queue, this will conclude today's stakeholder briefing. Operator, we do have a question in the queue, and we'll take that before we close.
Yes, our last question is from Bruce Friedman from GE Healthcare. Your line is open.
Yes, in the report, you mentioned that suggestions for possible diagnosis based on patient-specific information would be an example of a non-regulated application. And then you mentioned that computer-aided diagnostic software is something that has been regulated and would continue to be. Can you differentiate for me between those two cases?
Yeah, so computer, as you know, computer-aided detection software is then analyzing the radiological images to, if you will, highlight areas on that image that might be possible cancer, and then is really a decision support tool for a radiologist for them to go back and then ultimately make a decision, are they looking at cancer or not. We're looking at, on the other side, what's under health management, health IT, for the patient diagnosis are much sort of simpler tools that are used to help assist in a particular condition that a patient might have.
So if you were to look at it different, if you were to look at it.
Yeah, sorry. We're not looking at the kinds of tools that are either taking images of the body or they're measuring samples or specimens from the body. And instead, a lot of these are actually questionnaires that are being used by patients or practitioners, those simpler kinds of tools. But this is a great example, too, of one of the reasons why with the questions that we're posting in the public meeting that we want to work with stakeholders to clarify, first of all, any areas of ambiguity, but we think it's so important to continue to flesh out the kinds of functionalities that fall in these respective buckets, particularly in the health management, health IT category. Because we've tried to put out some examples, but we think, and we'll see what other folks say, one of the greatest values will be to continue to expand that list with additional examples. And we'd welcome, feedback from you and from others on where those lines should be and how best to do it.
Thank you.
Thank you again, ladies and gentlemen, for your time today. This concludes our stakeholder